Dear viewers, here I am with you today to speak a few words about polycystic ovaries. There is always lots of confusion between polycystic ovaries and polycystic appearing ovaries. When a sonologist or a radiologist perform an ultrasound, they tend to see lot of small cysts in the ovaries and they call it as polycystic ovaries. This is a wrong terminology. Such ovaries should be called as multicystic ovaries. So when do we call an ovary as polycystic ovaries? There should be all the small follicles or the cysts arranged all over the periphery in the ovarian cortex, and there should be not much of follicle seen in the medulla. So then we call them as polycystic ovaries. Per se, if you screen around 100 women, it's normal to find the polycystic appearing ovaries for 40 women. So are we going to treat all these 40% of women who have polycystic ovaries is an issue. Usually, many of them sustain polycystic ovaries and they remain asymptomatic. So we tend to treat only those women who are symptomatic. Looking into the symptoms of PCOS, the main symptoms are menstrual irregularity. They either come with oligomenorrhea or they come with a prolonged cycle of anovulation. So this is the typical finding in a polycystic ovarian patient. This is mainly due to anovulation. Following anovulation, many of them tend to have hyperandrogenism. The hyperandrogenism signifies that they have a high serum androgen levels. Due to the high serum androgen level, they tend to become hirsute, which means they have excess hair growth in the facial region, over the upper lips, the chin, the umbilicus, and so on. So following the hyperandrogenism, there is hyperinsulinemia, which means they become resistant to insulin, and due to the insulin resistance, they become overweight and obese. So this is a triad of symptoms which follows polycystic ovaries. So this is the main diagnostic criteria to name a patient to suffer from polycystic ovarian disease, which are ultrasound finding of polycystic ovaries and clinical history, wherein the patient gives a typical history of oligomenorrhea or prolonged anovulation and a withdrawal bleed, and features of presentation of hirsutism, hyperandrogenism, and hyperinsulinism. So how are we going to go about these women who approach us is another issue. This mainly depends on the age group at which they approach to us for management and their situation. So if they come to us pre-marital, the ideal option would be is to educate them about the polycystic ovaries and to advise them to lose weight and make them tend to go to their ideal body weight. So once they reach the ideal body weight, the hyperandrogenism and hyperinsulinism decreases and they tend to behave normal. So if they follow us after their marriage, the first option is to weight reduction, and then to know if they are anxious to conceive. If they are anxious to conceive, then we put them on ovulation induction drugs, pre-treatment with folic acid. So the ovulation induction mainly used these days is an oral clomiphene citrate tablet, which is ideally started from the 2nd or the to 5th day of their menstrual cycle for 5 days, and then we follow up them with follicle scans to look for the sign of folliculogenesis, ovulation, and close to ovulation we advise them to have a planned intercourse. So we assist them this way for 2 to 3 cycles, and when this fails, we then add on few gonadotrophins and supplement the treatment along with intrauterine insemination. They should be very careful in the use of clomiphene citrate, that it should not be used for more than 6 consecutive months, as there is increased risk of ovarian carcinoma in the later part of life. So after 6 months of use of clomiphene citrate, there should be a break or a rest cycle for 1 or 2 months, and then again we can put them for treatment. See, there is always a group of patients called resistant PCOS who don't respond to folliculogenesis ovulation with clomiphene or gonadotrophins. So treat this group is going to be a little difficult. They have increased follicle stimulating hormone level in their body. So the ideal option for them is to reduce their weight, and when they still tend to be anovulatory, is to either put them for ovarian drilling or for controlled ovarian hyperstimulation after downregulation. So when I say ovarian drilling, this is a laparoscopic procedure wherein it is done between the 6th to 8th day of their menstrual cycle. The ovaries are being drilled with an electrocautery. There are few side effects of this ovarian drilling procedure, like there is loss of ovarian cortex tissue, damage to the ovarian tissue wherein they lose the follicles and tend to have a decreased anti-Mullerian hormone and antral follicles following the procedure, and this in turn reduces their fertility. To some extent, this procedure causes adhesions with the fallopian tube, following which it becomes difficult for them to conceive or they will end up with ectopic pregnancy. Since the laparoscopic ovarian drilling has got side effects, the scenario is changing, and many of us are now switching from laparoscopic ovarian drilling to just drilling the ovaries with a needle, causing just physical injury without using any electrocautery. So by just causing this physical damage, the fluid rich in androgen is being let out, and there is reversal of hormones in their body. They subsequently follow up well with stimulation, and they have folliculogenesis and ovulation. So thereby, by not using a thermal current, we can reduce the complications of electrocautery. The next procedure would be is to down regulate them, bring down the hormones in their body under other control, and then to put them for an controlled ovarian hyperstimulation and subject them for an in vitro fertilization or intracytoplasmic sperm injection procedure. So this is the basic treatment for the patients who are approaching us from the fertility point of view. Following the fertility and the delivery, we have to advise them to be on long-term follow-up, as patients of PCOS have got high risk of turning into type 2 diabetes mellitus, getting into chronic hypertension and various coronary artery disease in the future. So polycystic ovarian disease or PCOS, polycystic ovary appearing ovary, is a triad of various symptoms with short-term and long-term sequelae of complications. So it is very ideal to advise these patients when they approach to us premarital or in their early married life that they should not be postponing their pregnancy, and it is always ideal for them to remain in their ideal body weight and to always have a follow-up with the concerned gynecologist.